unique unit that I want to make sure we cover pharmacology, but I also realize that pharmacology is something that most all of us are going to be looking up. So I just want to touch on some of the key things. I would like to make sure that I push you, though, to look at all of the slides. So when you think about pharmacology, right, where I want you as an exercise professional to understand that your job is we're not prescribing medicine, but we're looking up the medicine and understanding the physiology process of what the medicine or what that chemical is doing in the body. So when you take a look at the general principles about basic pharmacology or drugs, is they often have three names: a chemical name, a generic name, and a brand name, or the trade name, the kind of name you see advertised on television. The generic name identifies the drug no matter who the manufacturer is, such as, facial tissue, right? That's the generic is facial tissue. The trade name that you know it as might be Kleenex, right? So kind of understanding that it's the product versus what is the actual name. General principles are that drugs do not confer new functions on organs or tissues. However, what the drugs do is they attenuate or accentuate or replace a response, so they don't change the organ or the tissue, but they change how we uptake or how we process or synthesize. All drugs elicit multiple effects. Some are the desired effect and others are classified as unwanted effects. When you take a look at how do we routes of administration, enteral routes administered through gastrointestinal tract, either orally or rectally. Parental is predominantly delivered through the skin by an injection, so subcutaneous, intravenous, intramuscular, epidural, any of those. Pharmaceutical is how a drug progresses from the state in which it was administered, such as a solid, is integrated and then dissolved, right, into the solution, and applies only solid agents taken enterally, because parentally administered drugs are obviously already in that are already in that solution themselves. So the phases that the drug affects. The pharmacokinetic is the effect that the body has on the drug, how it's absorbed, distributed, metabolized, secreted, the bioavailability, so the route and through which it's going to pass. Inactive or bound, so usually to a protein or albumin, a state of where is it actually connecting in the body, and its half-life. How long does it take for half of the drug concentrate to be eliminated through the body? So pharmacodynamic effect of the drug is the molecules of the body. So it's the planned or therapeutic effect, that's your primary. The secondary is the unwanted or the side effect. We'll look at both of those, what it's supposed to and what are its side effects. The relationship between the amount of drug and the body's response is what we call the dose response. So the maximal response or maximal efficacy is the dose beyond which no further increase yields any further drug response. And the mechanism of action, the two main means by which a drug alters a bodily function at the target cell, mediated through a protein receptor found in the cell membrane. So kind of like that agent or keyhole. We have the agonist, the drug that leads to the physiological response, and we have the antagonistic, the drug that interferes with or counters the desired action. And then they influence or inhibit the normal effect of an enzyme. The statin inhibits the normal action of the enzyme liver. This is for cholesterol medicine. The HMGA-CoAs reductase, which lowers total cholesterol and LDL cholesterol. So again, the influence of where it's affecting. So for that situation I just explained is right, that enzyme, that statin medicine. The mechanism of action is what we call the TI, the therapeutic index. It refers to the safety of the drug and is represented by the ratio between the dose that is lethal in 50% of the animals being tested and the dose that is therapeutic effective in 50% of the animals. So that's what we call the therapeutic index. It's safety. So when you take a look, here we have how much time over the concentration of the drug in the plasma if you take the initial dose. Here is our minimum to be effective. Here is our minimum toxic concentration. So when you look at the TI, the therapeutic range or the therapeutic index, it's somewhere between the minimum and that maximum of trying to figure out where is that sweet spot that's the right milligrams, the right dosing. How do they figure out that? Well, when you're looking at prescribing, again, when the doctor is prescribing the medicine, factors that are going to modify the physiology of how the chemical works in the body and how much somebody needs is going to be their age, body mass, right, fat versus muscle, how much they weigh, their gender, genetics coexisting to other diseases, are there any placebo effects or kind of the person's mood, are they on a placebo to real medicine, environment, time of day, where it's being uptaken in the GI tract. We also want to talk a lot because in older populations, which is this class is geared to more chronic diseases and kind of the unfit people, we have non-compliance versus persistence. Non-compliance are commonly what we see. So these are people not filling the prescription, people not taking the medicine as prescribed. Sometimes it's because it's costly, too expensive, related to increase. So what happens is they're not taking the medicine as they should, and they're in the hospital. They're missing work. They're not well. Unnecessary deaths. So people who think they're saving money by rationing out their medicine or not filling the prescription usually leads to heftier cost on our system because the person is not well. So when you look at the non-compliance, these factors related to non-compliance, so symptoms, absence of symptoms, health beliefs or health literacy, what are they understanding, what kind of support do they have, what is their disorder, is it chronic or acute, right? Is it ongoing or is it just a one-time thing? Cognitive impairment, or what is their mental state, what are their understanding, drug-related side effects, multiple medications, we call that polypharmacy, multiple doses, it makes things confusing, and a lot of times all of these can compile and result in more non-compliance, or higher non-compliance rates. The other thing with non-compliance are improper medication use, or not filling the prescription, not taking it as prescribed, over or underusing, either not taking enough or opposite, they're taking too much of it or taking it at the wrong time, confusing their medicine. A lot of patients mistakenly are taking the wrong medicine at the wrong time. They're doubling the dose of one and not of the other. Never finishing the medicine is another. There's many medicines where you need to be on it the entire dose for it to really be effective. You see that a lot with your antibiotics. Administration errors, like I mentioned. Taking someone else's medicine is non-compliant, and using old expired medicine is another problem. So what do we do to help improve compliance? What is your job as a fitness professional? So you want to use a living room language, right? You just want to be able to talk nonchalantly without using big fancy chemical names. Picture demonstration, we do a lot of teaching back. The teach back method is I explain and then they've got to repeat that back. Self-monitoring is another one. RIM, recognize, identify, and manage. So recognizing using objective and subjective evidence so the pharmacist can determine if the patient has an existing compliance problem. Identify the cause of the non-compliance. Is it finances? Is it support? Is it maybe their literacy? Maybe it's their vision and they can't even read what it says on the label. Manage, develop partnerships with the patients, kind of being able to build a relationship so we can identify more. So for improved compliance, patients are going to have better outcomes. They're going to feel better, quality of life. The practitioners, healthy, more loyal to the patients, the better trust. In managed care situations, lower healthcare dollars are being spent. Obviously, the pharmaceutical industry is going to benefit because we're buying more of their medicine. So medical reconciliation, formal process that compares a patient's current medications to those of a medical record or medical orders that have been meant to identify any errors. Right, mistakes can happen. So between the doctor and the pharmacist and whoever the healthcare provider is, so omissions, wrong dose, wrong frequency, wrong medicine, duplicate drugs, all of these errors can lead to increased mortality, really difficult. So what I want you to realize as an exercise professional, I want you to be familiar really with medicines, with how they're administered. I want you to understand how they act, look it up. Right? I'm not going to memorize these. I'm going to look up the medicine. If you have a client on medicine, look up what the medicine is. Look at the physiological response. Look at how it's going to change their exercise response. And then really help learn about this client and learn their compliance. So really learn about the agents, learn when they're taking them. Are they taking them with the meal? Are they in a routine at the same time of the day? Where do you get information about drugs? You're going to find all of the drug information, right? The pharmacological drugs in your basic guidelines book, right? The GETP, right? Exercise guideline testing for ACSM book, right? Back there you can hop and see. You can also find information in any of your cardiac textbooks. Is another good one, obviously online as well. When you're looking at pharmacology, I want you to be able to understand the basics of the cardiovascular system, right? So the cardiac cycle, cardiovascular physiology, the autonomic nervous system, because that is what the chemical is going to be primarily interacting with, right? Sympathetic or parasympathetic system is usually what we're seeing. When you think about the autonomic nervous system, it's widely distributed throughout the body. It's controlling our functions, both blood pressure and heart rate. And when you think about the ANS, we have the sympathetic and we have the parasympathetic system. With the sympathetic nervous system, it is diffusing or innervating many components of the cardiovascular system. The primary neurotransmitters norepinephrine or noradrenaline. The adrenal medulla is the component. The primary neurotransmitter is epinephrine. It's going to have target organs, receptors for what we know as adrenergic receptors. So I'm telling you all of this because this is where the chemicals are going to bind. Common organs with receptors: vascular smooth muscle, the heart, the kidney, bronchial smooth muscle. When you look at the parasympathetic innervation, is usually going to be through the vagus nerve, much more discrete, limited to just the SA node and the AV junction. Little or no innervation of the ventricle or the blood vessels. The primary neurotransmitter is going to be acetylcholine, and receptors are going to be the heart, right, the SA node, the AV junction, and the endothelial, so the endothelium release factors. So you're basic that you already know. You've gotten this far through this class, you've gotten through anatomy and physiology, you kind of know the basics. So when you think about pharmacology, this chapter, I want you to be smart and I want you to look up your client's medicine and I want you to know what it is you're looking for. So before we get into the actual different classes of medicine, controlling blood pressure, we have two ways that blood pressure is controlled. We have resistance and we have capitance. The resistance vessels are arterioles. They control mean arterial blood pressure and blood flow to specific tissues. Vascular smooth muscle is controlled by the sympathetic nervous system and basic through metabolic need. When we look at the capitance vessels, these are systemic venules and veins. It's the volume of reservoir for the circulatory system. Sympathetic or humoral regulation of vessels can significantly alter what we know as venous return. So again, resistance versus capitance vessels are when you're looking at how blood pressure regulation happens. So mean arterial blood pressure is going to be monitored through the barrel receptors. That's in the aortic arch, in the carotid artery. It is primarily regulated by integrated reflex pathway of baroreceptors or through feedback loops. Short term, seconds to minutes, is going to be mediated through the autonomic nervous system, and long term, days to week, through all of those different hormonal factors that control blood volume, regulate sodium, water retention. So what we want to get at with understanding drugs is they can be classified in many different ways. I'm going to look at some of the major classifications in this chapter. I want you to be smart, know where to find the information, right? Where do you refer to find medicine information? So for this class, our major drugs are going to be ACE inhibitors, antihypertensives, so those could be beta blockers, calcium channel blockers, antiarrhythmics, diuretics, anticoagulants, anti-anginas, and the other one that's not on here are antilipemics. I am not going to just read the rest of these slides to you. I want to just give you an example. So each one of these, it's its class, and under the classification are lists and lists of other medicines that fall under, let's say, ACE inhibitors. In no way would I ask you to memorize pharmaceutical medicines at this level of your education, right? I want you to know that each of these different major categories, classifications, serves a point, and then within them are different chemicals that have a very similar mechanism of action. So for example, if we just look at the ACE inhibitors is a very, very common cardiac medicine used for blood pressure, heart failure. We see it a lot post-MI to increase the length of survival rate with MI patients. The physiology of an ACE inhibitor is that it activates the hormone, you know, is angiotensin, right? That's what ACE inhibitor stands for. And it's going to cause blood vessel constriction. So once we end up activating angiotensin, it's going to cause blood vessel constriction, and it's going to result in an increase in blood pressure, and that is what we're going to see. Heart strain, ACE inhibitors are going to inhibit that angiotensin and prevent activation of angiotensin. So what's going to happen if you don't allow the angiotensin, which is known as a vasoconstrictor, to happen? The reverse happens and you have vasodilation, right? So what does vasodilation do? It's going to lower the blood pressure. So what does that mean to us? Well, not really a big deal. We're not going to have a change in heart rate. Blood pressure usually going to be lower. EKGs, no big change. Exercise capacity is pretty much the same. This is just a small list of ACE inhibitors, right? Low tensin, capitin, vasotec, altase. The problem with ACE inhibitors, you see this all the time in cardiac rehab, is patients complain of a dry, annoying cough. That dry cough is usually caused by an ACE inhibitor. So when you think about an ACE inhibitor, that's all I want you to know, right? I'm not going to ask you to memorize medicine. I just want you to know that it's a vasodilator, used to lower blood pressure, increase quality of life post-MI. The dry cough is a common one. So I'm not going to go through all of these. I think that I've got the slides there and you can read them. I know that listening to my YouTube videos can be long and boring and I don't want to put you to sleep. But each of these classifications, I'm going to go through the same thing. I'm going to tell you, what do we use the medicine for? The physiology is, what does the physiology do to the body? And then an example of what it does in exercise: heart rate, blood pressure, EKG, exercise. For an example, with beta blockers, it is going to change their exercise heart rate. You're going to have a blunted heart rate. You're going to have a blunted exercise response. Exercise capacity should be increased, though, with patients with angina. They can usually do more. So for beta blockers, lots of side effects, lots and lots of side effects. What are some examples of beta blockers? The list is here. So what I've done in the next few slides is told you the classification, explained to you what the role of medicine is, explained what the physiology is, give you a few examples of different types of medicine, and then what I want you to know is exercise capacity. So the assignment for this week is each of you have been assigned your own medication, right? So each of you have been assigned your own medication. And in that medication, you're going to look, because this font is too small, I'm going to do some investigating. I want you to tell me everything you know. I want you to answer this in a basic short answer. It does not need to be essay response, kind of short answer. Look these up, go online and take a look at the physician desk reference and be able to, the PDR, the physician desk reference, has a website, and be able to show me that you are able to tell me the brand name, the chemical name, the drug maker, the cost of the medicine, and that is kind of the gist of pharmacology. So you don't have to memorize the medicine, but I want you to know what are the major classifications of cardiac medicine and what do you need to know as an exercise professional to understand the response of how that chemical may change exercise response.